Right. Well, good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today and pay my respects to their elders, past, present, and emerging. A little housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you can submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. So today we'll be hearing from Dr. Andrew Gilbert. Andrew is a research fellow in the Social Gerontology Division at NARI. His research interests include health and aged care systems, including organizational issues and policy. And since 2018, he's been working on projects related to raising dementia awareness among CALD communities. Today, he's going to be presenting Emotional Care by Culturally and Linguistically Diverse Carers of People Living with Dementia. So welcome, Andrew, and over to you.
Thanks, Jessica. Pleasure to be here. So the title of today's presentation is Emotional Care by Ethnic Minority Carers of People Living with Dementia. The data this is drawn from is from the Moving Pictures Project, which is an ongoing project where national researchers at National Aging Research Institute have produced videos about dementia awareness, dementia caregiving targeted to culturally and linguistically diverse communities. And so this paper is sort of a joint effort through between team members. I'm presenting it, but also Josephine Antoniadis, Samantha Croy, and Bianca Brezhnev are also authors of this paper. So when we think about dementia and as an emotional experience, we're not just thinking about it for the person living with dementia, but also for their loved ones. And the gradual loss of human capacities is often very distressing for the people experiencing it and the people, who they're sort of close relatives. And people can feel like they're losing important parts of their identity and personality, and they might find themselves in situations they find embarrassing, such as forgetting people's names, making mistakes, incontinence, things like that. Consequently, when we think about emotion and dementia, it's often in a very negative way. So dementia is often associated with fear, depression, anxiety, anger, confusion, emotions like that. But I think it's also important to point out that it's not exclusively negative. There can be also be positive emotional experiences such as joy, love, and affection. Another thing to think about when we're talking about emotions and dementia is the role of culture. So our cultures play a big role in how we interpret dementia and how we feel about the symptoms. And we all belong to cultures, every one of us. But something like stigma is something that manifests in different ways across different cultures. So in Anglo-European cultures, such as like what I'm from, we tend to grade a person's worth by their individual achievements and their capacities. And when someone's capacities decline and they are more dependent on others, that can lead to some stigmatization of that person. And in some ways, Western medicine mitigates this because it sort of portrays that decline as something that's not your fault. It's an illness that you don't have control over. But in other cultures, the idea of dependency and care can be viewed in different ways. So in other cultures, it's perhaps more expected that as a person gets older, that they'll need care from other people, who are close to them, and that's nothing to be ashamed of. But there are other stigmas that might be attached to dementia, such as in some cultures, dementia might be viewed as a curse or something related to the family. Dementia might lead to awkward situations where a person which people find embarrassing or awkward. And medicalisation can sometimes itself be stigmatized. So labeling a person with a diagnostic category such as dementia, can sort of create an idea that, well, there's something wrong with them. They're not a normal person. That's not normal aging. And also, in some languages, the term dementia translates into very emotionally loaded, pejorative terms, such as the example I have here is ania in Greek, which means out of your mind. But in English, like senile dementia was a term that used to be used, but that we no longer use that term because it actually has quite pejorative connotations. So all of these things, these cultural things can affect how a person with dementia experiences that condition, but also how the people around them perceive that. So what I was interested in this study was to apply the sociology of emotions to the experience of caring for a person with dementia. I'm a sociologist by background, and so I was sort of interested in how that field of sociology could be brought to bear on these questions. So as a way into this, I'm going to quickly try and run through some key concepts in the sociology of emotions, just to give you an idea of the field. So a really significant, I guess, figure in the sociology of emotions is Erving Goffman, who many of you probably know of for his work on stigma and asylums. In his early work, he talks about this idea called face work, and he draws the idea of face actually from Chinese culture, and the idea that whenever we're going into social situations, we have to behave in an appropriate way to keep face, and if we act in an emotionally inappropriate way, we can lose face, and this affects our reputation and it makes other people feel uncomfortable. And he was very interested in the dynamics of this. Someone who was extremely strongly influenced by Erving Goffman is Thomas Sheff, and he wrote a lot about shame. And he argues that shame is the quintessential social emotion. He says that we feel shame when we tend to break social norms or behave inappropriately, which causes other people to judge us. And therefore, we tend to follow norms and manage our own behavior to avoid these unpleasant feelings. But he talks about people who are mentally ill or neurodivergent who might find it difficult to always act in a way that's appropriate to a situation, and they may perceive others judging them or things like that. And this can amplify the social exclusion and the shame that these conditions can bring. Ali Hochschild is quite a famous sociologist, and she talks about this idea called emotional labor, and she drew this idea from a study of airline stewards and stewardesses. And she's interested in how people in those positions must manage their own emotions in order to, by extension, manage the emotions of other people. So airline stewards and stewardesses have to maintain a positive demeanor, despite what the customers say or do, in order to kind of keep a positive atmosphere in the workplace. And if they don't, they're not really fulfilling their service. And finally, Randall Collins, he's more recently written about this idea of emotional energy. And he talks about how, we go through life with reserves of emotional energy, which when we have a good, positive social experience and, a happy experience, our emotional energy increases. And then the next situation we go to, we're sort of there, and we use that and we lift the situation. But if we have negative experiences, it sort of depresses us. And this can be a kind of feedback loop, because then the next situation we go into, we're depressed and down, and we find it difficult to kind of liven up the situation. So he's interested in that idea. So before I move on to the findings, we'll talk a bit about the method. The study's based on interviews with 63 carers from culturally and linguistically diverse communities. The languages they spoke were Mandarin, Cantonese, Tamil, Hindi, Arabic, and Italian. And they were semi-structured interviews, which were video recorded. And it's important to point out that our analysis is of the carers' emotions and perceptions of emotions, and not people with dementia. We didn't interview people living with dementia in this study. So in what the carers said, when they spoke about the early signs and early stages of dementia, they often gave extremely emotionally laden descriptions. They spoke about their relatives being socially withdrawn. Often carers would attribute shame or embarrassment to the person living with dementia and sort of assume that the reason they're withdrawing is because they're ashamed of themselves, ashamed of their own actions. They also spoke a lot about conflict and arguments as a sort of sign that things were not all well. So, you know, a parent who used to be quite a calm person suddenly is getting angry more often. There's lots of arguments and conflict within the family, and the carers are getting upset too. So these were all sort of seen as the early signs that a family member is developing dementia. Social alienation. So I'll read out this quote. If a group of relatives came home or friends came home, he felt that because he was not participated, they were talking to someone else or his wife, then he felt he's being alienated. That set him off and he got very angry. This was very new to him. He's never gotten angry before. So the idea here is that all of a sudden, Kamala's father-in-law starts to feel left out of social situations, like he can't participate, and that gets him angry and upset. He feels alienated and creates conflict within the family. Another side to it is the shame and embarrassment that carers felt, which came up quite a bit. Often carers would say that they felt ashamed of the person living with dementia because they felt that they were kind of losing their capacities or losing their personality. So as this carer said, I was ashamed for my father because he found himself in situations where he'd be in a conversation with someone who would correct him. So it's a sort of a sign that you know he's not communicating with other people in the same way he used to. And this sort of brings shame on his daughter. And also social status. So this carer says, my mother normally in the community, she's a doctor. So she's someone of social status. We felt very embarrassed by the dementia. We thought about not taking her outside, seeing friends or going to church. So there's this idea here that it's not just shame and embarrassment for the person with dementia, but also their family. Like an important member of their family is losing status, losing their capacities within the community, and it's bringing shame onto everyone in that family. The carers didn't speak a lot about stigma, but probably probably more so in the Chinese interviews, it was evident than in the other cultures. So this carer says, the Chinese have a saying, shame of the family cannot spread outside. This is a very important saying because after an elderly person gets dementia, a lot of their behaviours become abnormal. The symptoms worsen, the people around them cannot accept their behaviours. That is why the people around them don't want to spread it. This is a fear of losing face. So what she's talking about is that the family of a whole feel like when the member of the family is developing a condition like dementia, that the whole family is losing face. And there's an expectation that the older relative should be prevented from sort of embarrassing themselves in public situations, and that the family should protect them from that, to sort of protect their reputation. Another idea is that came up a bit is that shame, that negative feelings and shame in particular accelerates the symptoms of dementia. So as this carer says, when incontinence occurs, she felt very ashamed. She felt very dissatisfied with herself. If the family gets angry at her during this time, she blames herself even more. Her self-blame accelerates her condition. So what this sort of leads into is that carers say that they start to see that being an effective carer was really about ensuring positive emotions, about not getting angry, not blaming the person, and learning how to manage their own emotions. So here we sort of have evidence of this. Carers variously talked about how they learned to control their own emotions, their own feelings, in order to get past the frustration and the anger that they occasionally had. And so as Gianna says, I've learned to calm down, to not let things stress me out, and I just go with the flow now. And there's also this idea that emotions are reciprocal, that if the carer kind of brings negativity into the situation or reacts negatively, then that is a sort of reciprocal feedback loop with the person with dementia. And so Ling Chen expresses this quite well, I think. She says, if you're mean to them or bully them, they will know it. She is aware of it. This will create a malignant cycle. It's either a benign cycle or a malignant cycle. Each day you must maintain a sunshine attitude. That is very important. Each day you must tell yourself more kindness. So she's sort of saying that every day she has to remind herself that she's got to be positive and happy and have a sunshine attitude in order to avoid ending up in a malignant cycle between her and her mother, where they're both becoming increasingly negative towards each other. So there's various ways that carers told us how they learnt to do this. A very common thing they said was to sort of perceive the person living dementia like a child. And so as Aisha says, you cannot be hard with him. You need to treat him like a child. Otherwise he would be aggressive, and I don't want him to be aggressive. And so what they sort of suggest is that it's inappropriate to get angry at a child, because a child is a person who doesn't necessarily have full control over their emotions. And so by treating her husband like a child, she can, I guess, adopt a kind of maternal position where she can see herself as being responsible for maintaining, I guess, a positive demeanor, a positive face. Another strategy was through medicalisation, or seeing dementia as a medical condition. So sometimes carers would talk about, their family member as having a medical problem, and that it's important to remember it's a medical problem, and that this achieves what sociologists sometimes call distanciation, which is the idea that you can emotionally distance or disassociate yourself from a situation and look at it in a kind of neutral, objective way. And so perceiving a person with dementia as a patient means that they can look at whatever they're doing or whatever they're saying as a symptom and not take it personally. And it also means that someone with an illness requires care, like the carer is responsible for providing care. So thinking about it that way helps them adapt to the sort of emotional demands of the caregiving role. But it's not always family care. So in this example, she's actually talking about nursing homes. So she says, I feel like now, like us, we are well informed about these things. And maybe the minute we said onset of dementia, most of them said, are you getting help? We said, yes, we have put in a nursing home. They said, the best thing you did. all knew that this was the best. There was no guilt. It is a health issue. So for some carers, they talked about looking at dementia as a health issue, as a way of justifying to themselves that their family member could go into residential aged care or could get home care or things like that, because this helped them get over some of the stigma towards these things that existed in their community. So returning to the idea of emotional energy, so in this idea, emotions are resources that you bring into a situation and that influence others around you. And so if you're in a more negative and emotional state, it's difficult to create a positive atmosphere. And so the idea of emotional energy is we need to sort of ready ourselves for certain situations and sort of charge ourselves up if we're to sort of perform in certain ways. And I think Katja expresses this incredibly well. She says, your energy must be positive to be able to enter inside. So when you enter the room with her or sit with her, you absorb many negative things. So your jug must be full to be able to care for her. So you return active, strong, because you spend your time with them at home and all energy nearly gone. Whenever my jug is full, so I am psychologically comfortable and willing to accept the situation. And so she talks about how, as a carer, it was very common in among Arabic families to sort of rotate the caregiving responsibilities so that one of the siblings could get respite, could take a day off while another one is providing the care. And this was very important so that everybody was able to sort of maintain a positive atmosphere, maintain a positive state, and provide the best care for usually their parent. So to summarize, according to carers, initially the early stages of dementia was marked by predominantly negative emotions for both the person and their family. And they spoke variously about grief, shame, embarrassment, and frustration. There was a common kind of idea of trying to shelter the person with dementia, often from the community. So often the idea is that there's these small migrant communities with quite densely woven social networks. And the carers are worried about their family members' status within those social networks. They don't want them, they don't want people looking down on them, that sort of thing. And so sometimes they talked about a desire initial desire to shelter the person, to not let them go to a church or a community group or things like that, out of a fear of judgment or a loss of status. But often that was seen as counterproductive. And carers went through an emotional adjustment process. They learnt to manage their own emotions in order to sort of adjust to their caregiving responsibilities, but also to be able to create a positive environment, which they saw as an integral part of providing dementia care, perhaps the most important thing. And they used, in order to enact this switch, reframing strategies, such as thinking of the person like a child or thinking of it as a medical condition. But they also talked about the need for respite, because caregiving, it did affect their emotional energy. It did drain them of emotional energy if they didn't have respite, time to recuperate, things like that. So there's respite and recuperation was important. And so that's it. There are the references. And here's the team members of Moving Pictures. And if you're interested in watching our videos, you can follow this link.
Great. Thank you very much, Andrew. We now have some time for Q&A. So if you have any questions, please submit them now through the chat function. Alternatively, if you'd like to ask your question in person, you can turn on your camera and microphone and we'll be able to call on you in turn. Andrew, would you mind perhaps stop sharing your screen so we can see everyone clearly in case they would like to ask a question?
Yep, just a sec. Yep.
Great, thank you. Well, while we wait for people to pull their questions together, I had one. You mentioned that stigma was a more prevalent theme in your Chinese participants. Were there any other themes that were more particular in a prevalent or a particular CALD community?
Yeah. So there were some things were fairly universal, like that idea of, you know, of social withdrawal, for example, and anger, fights, arguments, conflict. But there were things that were related to, definitely more common in certain communities than others. So that idea of face was, and the idea that someone with dementia could lose face if they, you know, went to their church or something and did something like forgot someone's name or experienced incontinence, that would be a loss of face and a loss of status. That was probably more commonly expressed among Chinese carers, but other carers did sort of allude to these things. Things like, so the other thing to think about is migration patterns. So for example, South Asian carers tended to be smaller families, so perhaps just a married couple taking care of the parents, whereas other communities such as the Arabic community tended to be larger, like they'd have more siblings in Australia. And so that changed the way they managed it. So South Asian carers probably relied much more on formal help and things like that, whereas the Arabic carers would do much more organising within the family. So those are some of the differences, yeah.
Interesting. Joan comments, fantastic presentation, Andrew, so well grounded in theoretical constructs. Joan, did you have a question that you'd like to ask Andrew?
Yes, thanks, Andrew. That was really interesting. I'm interested in how you're going to build on this. So do you have a sense that when people are aware of their emotions, that they're better placed to deal with them, which begs the question of an educational intervention?
I'd say yes. And actually the interesting thing is that, which maybe I should have mentioned this, is that a lot of what the carers talked about when they talked about becoming a carer and about the importance of managing their emotions being central to that process of becoming a carer. Many of them were talking about geriatricians or nurses and people like professionals like that who'd sort of supported them through that process, who'd sort of informed them about, you know, this is how you should behave, this is how you should feel about this situation, you know, don't try not to get upset, don't take these things personally. So I think that's already happening. That's already happening. That sort of education, and obviously it'll continue to happen and can continue to happen. Yeah.
Thank you.
Our next question is from Anita. She says, very interesting, thanks. It'd be fascinating to see how the views of different groups of Chinese participants differ or don't differ, such as Cantonese speakers versus Mandarin speakers, North versus South, first generation versus second generation, and the effects of acculturation. Is there anything you'd like to comment on that?
I think that's a really good comment. We had a very mix in our group. Some people had been So I think part of the way to view the Chinese culturally, like the group, is as a diaspora. So some people were Cantonese speakers who come from Malaysia, and some were Mandarin who'd come from China. And there's probably are differences in the way, in the way they perceive dementia, but we weren't really able to pick up on that, I don't think, because we weren't focused on Chinese culture as such. But I think that's a very interesting question. Yeah.
The next question from Felicity is, thanks for your presentation, Andrew. You talk about shame or people losing face. Do you know if this is a valid concern? Are there cultural differences in communities about how people view someone, not a family member with dementia? Is there judgment about the person living with dementia or about the family?
Well, according to carers, sometimes there is judgment, but I think that the thing about the way we collected data, which is through interviews, it's more about that the carers perceive there's judgment, and so we're not doing an ethnography. We're not there, sort of in the field, seeing whether that's really there. But the important thing is that carers perceive that there's judgment from the community, and this changes the way their perceptions of that change the way they feel about the situation. So I think it's so it's hard to answer whether it's valid or not. Like it's because it's sort of coming from these interviews. But one thing that I think stands out is the sense that sometimes there's an older person who's been quite a significant member of a community, who's quite revered in that community, and developing dementia, their family is extremely worried about what's going to happen to that status, as their symptoms worsen. And so that is, they're sort of perceiving that there'll be a judgment against their relative and them. Whether that happens or not, I don't know if you'd need a different sort of study to measure that, I think.
I've got another question. You had a lovely slide at the beginning of your presentation that mentioned many of the specific factors around dementia that were relevant to CALD communities specifically, such as stigma and terminology. Were there any of those that didn't appear in your study that surprised you?
Stigma wasn't probably as big as we made out. I think, and this is another limitation of the methodology. So we're making films to increase dementia awareness. So people are on board with that idea, with that project. And so they probably don't have, or they're not going to express to us anyway, stigmatizing views about dementia. And so it didn't come up a lot. Mainly it was about other people directing stigma at them. That was somewhat surprising. And sometimes, and another thing was quite often carers would downplay the role of stigma. Like they'd say, "Oh, we're a younger generation. We're enlightened. We don't sort of think like that. Like we have a much more medical understanding, So that's perhaps surprising, but then perhaps not actually. Yeah.
An interesting selection bias there. Well, if there are no more questions for Andrew, would you please join me in thanking him with your clap reactions? Our seminars in ageing next week on Tuesday, the 19th of October has unfortunately been cancelled. But we are looking forward to seeing you again in 2 weeks' time when Professor Colette Browning will be presenting sensory loss and quality of life in older people. So thank you all for attending our seminars in ageing program, and we'll see you again in 2 weeks' time.